I'll go ahead and start talking if y'all are okay. Thank y'all for inviting me to Food for Thoughts. I've spoken here before. I'm Randall Squires. I'm a gynecologist. I have a special interest in breast cancer and developed a special interest in it 5 years ago in that I started doing genetic testing for inheritable cancers. And today we're going to generally speak for about 15-20 minutes about breast cancer. Y'all can feel free to interrupt me, ask me any questions. Can all of y'all hear me? Can y'all hear me back there? So I'll stand maybe around here and try to spin. Anyway, I'm a gynecologist, advanced GYN. I've been here 21 years. I used to practice in Conway. I was there 10 years. And I'm from Aner. Everybody knows where Aner is. UCLA. You know what it means? Upper Conway, Lower Aner. International. And so today I'm going to be speaking about breast cancer. And basically, breast cancer is the most common cancer in women. 1 out of every 8 women will get breast cancer. But we also have to realize that men get breast cancer too. And less than 1% of men will get breast cancer. What we're going to talk about today is what risk factors there are for breast cancer and how to reduce the risk. And basically, one of the main ways to reduce the risk is based on avoiding alcohol, smoking, try to maintain a good body weight, and let your doctor know about your family history. You can adjust, you can try to avoid smoking. I know it can be difficult. You can try to avoid alcohol. That can be difficult. And you can try to maintain a good body weight. All of those are very difficult. So you can change alcohol, smoking, and your weight. You can't change your family history. And your family history can be one of the most significant factors involved in your risk of having breast cancer. Let's see if I can find my... So bottom line, 8% of women will get breast cancer, less than 1% of men will get breast cancer. As I said, smoking, alcohol, obesity, and a family history. Now, what does the family history lead to? The family history leads to what I have a special interest in, and that is testing to see if a person has a gene that can cause breast cancer. Bottom line is, everybody has cancer cells in their body. Everybody. Most people have tumor suppression genes. In other words, they have genes in their body that kill the cancer cells before they become clinical cancer, before they cause a problem. And most people, their immune system works that way. But a small percentage really of those people that qualify to be tested, I guess what I should say, 10% of people qualify to be tested to see if they have an inherited cancer. And of those 10%, 7% will have a gene that can cause cancer. Bottom line, so when you go in to see your family doctor, ideally he'll ask you about your family history of cancer, and he'll take note of it, and if there's anything significant, he'll talk with you about being tested. So if you qualify to be tested, he'll test you. And then if you have a gene that can cause breast cancer, not only can it cause breast cancer, it can cause other cancers too. Because remember, it's a tumor suppression gene, so it just doesn't pick cancer cells to fight. It can pick breast, ovary, uterus, colon, stomach, melanoma, prostate. It can pick all those cancers. And everybody probably knows Angelina Jolie, Brad Pitt, they get in a divorce. He got mad at one of the kids, I guess. Anyway, Angelina had a family history of cancer, and she had the gene. There are 28 genes we check for. Each gene can cause several cancers. Her gene increased her risk of at least 3 cancers. Her gene increased her risk from a routine risk of 1 out of 8 chance of getting breast cancer to 87%. Because she had an 87%, she could have opted to do some things we're going to talk about. She could have opted to be watched closer, meaning she could be checked by a doctor every 6 months. She could get a mammogram every 6 months. And to add to that, she could get a breast MRI every 6 months. Doctor every 6 months, mammogram once a year, breast MRI once a year. What's the thing about that? To pick it up earlier. And she may have done that for several years because she knew before she had her mastectomy that she had the gene. But at some point she decided the risk was enough that she decided to have her breast removed. She had the gene that caused ovary cancer. Watching for ovary cancer doesn't work too good. Usually it's already spread. We know that anybody that has taken birth control pills for 5 years cuts their risk of ovary cancer in half. She may have had taken birth control pills in the past, but the bottom line, the usual risk of ovary cancer is like 1%. Hers was 44%. And she knew that watching wouldn't help, and she knew that when you find it, it's usually advanced, and so she had her ovaries taken out. Now, she had her tubes taken out too. And that's something we figured out about 4 years ago. Almost all ovary cancer starts in the tubes. And that's why now we recommend any lady that has a sterilization really should get her tubes out. Not cut, clipped, tied, or burnt, but out of her body in a jar on the shelf. Because that's where the cancer usually starts. And if y'all get the monthly hospital magazine that comes out, or is it quarterly? Quarterly magazine. I had an article about a year ago that I had a patient that actually is a nurse here that had a family history of ovary cancer. And I tested her. She didn't have the gene. She didn't have a 44% risk of ovary cancer, but because she had it in her family, she still had that risk. And I said, you know, you don't have the gene, you don't have a 44% risk. Because you have a family history, your risk is anywhere from 5 to 10%. And she didn't consider it significant enough. She didn't want to do anything, that was it. 6 months later, she developed some bleeding problems. I said, let's do a D&C. But I said, you know, your tubes, I really would like for them to be in a jar, sitting on the shelf, because you still are at risk for ovary cancer. Even though you had the family history, you didn't have the gene, you still have the risk. So I did her D&C and took out her tubes. She had pre-cancer in her tubes. So we prevented cancer. And I've had that happen a couple of times over the last few years. So just remember, if you have a family history of cancer and you do get referred for testing, you're not off the hook if your test is negative. You still have risk, you just are not at a high risk, you're at a moderate risk. You know, bottom line, I divide everybody into a category, a cancer risk category. That risk is low, nothing significant. High, Angelique Jolie, they got the gene, they might want to get some things removed. Moderate, they don't have the gene, but they have the risk, and they might want to be watched really, really close. So bottom line, I do the genetic testing. It's a gene mutation. Everybody has cancer cells. Most people can destroy the cells before they form cancer. Some people have a mutation in the gene. They can't fight the cells, and they develop cancer. It's salivary. You can just spit into a little vial or have blood drawn. Most insurance covers it. Unfortunately, Medicare does not cover it. Yeah, really. As prevention, Medicare does not cover it. They will only cover it if the person, meaning you, had cancer. And then you say, well, if I already had the cancer, why get tested? Actually, you still should be tested So if you had breast cancer at an early age, that's a risk factor, less than 50, or it was bilateral breast cancer, or if it was estrogen negative, or that in your family. And it matters just as much, the family history of cancer on the dad's side as the mom's. Equally important, just as important if there's cancer on the dad's side as it is the mom's. But you say, well, I already had breast cancer, what does it matter? Well, you could have the gene that causes other cancers, that causes ovary cancer, that causes melanoma, that causes pancreatic cancer. Unfortunately, pancreas cancer, there isn't anything to do. Angelina Jolie, most people have a less than 1% chance of getting pancreas cancer. She has up to a 7%. Unfortunately, there's no medicine she can take to prevent it. There's no surgery she can have to prevent it. And there's no way to screen for it. They got a test, a study going on at Johns Hopkins now where they go down your throat and do an ultrasound of your pancreas. They don't really know if that's going to pick up pancreas cancer early or not. How are the tubes removed? Virtually always laparoscopically. Belly button cut here, about the width of your fingernail. 2 more little cuts here, go in and remove the tubes. Laparoscopically, outpatient surgery. I do probably 95% of the surgery I do is laparoscopically. And you know, hysterectomies and take out the tubes and remove.
If the tubes are tied.
If the tubes are tied, a good point. If the tubes are tied, we know it cuts down on the chance of ovary cancer some. If the tubes are in a jar on the shelf, it cuts the risk as much as 75%.
If you have a hysterectomy, do you remove the tubes too?
Up until 4 years ago, not routinely. But when we figured out about 4 years ago that the cancer of the ovary starts in the tubes, I started removing the tubes. The recommendations are the tubes be removed. Everybody, you know, it takes a while for people to catch on, so everybody does not remove the tubes when they do a tubal now, but you really should talk your doctor into taking your tubes out if you have a sterilization.
If you have a complete.
If you have a complete,
Hysterectomy.
you know, a complete, that's hard to say. Nobody knows what a true complete is. Some people think a complete, when they tell a patient a complete, that they took the uterus, tubes, and ovaries. Some people, doctors say a complete is completely removing the uterus. So you'd have to ask your doctor, were the tubes and ovaries removed?
What about when you did a complete hysterectomy? What did you do?
Up until about 4 years ago, I did not routinely remove the tubes.
How do you find out?
Pull your op note. You call the office and if I did your surgery, or if it were done at Baptist Easley, we could pull the record. But
I always just assumed that everything is gone.
Yeah.
But maybe it's not.
but help me remember and call the office and ask us to pull your record. But we didn't know until about, I'm gonna say 4 years ago, it might have been 3, to take the tubes out.
About 20 years when you first came here.
So I would not have, unless there were a problem. But now, if I took out your ovaries, I took your tubes.
But you did.
I took
But
your tubes out.
But I will call the office. to
Yeah.
check.
It would be not smart to remove the uterus and ovaries and save the tubes. I mean, I would take your tubes if I took your ovaries.
I think you did.
Yeah. Okay, so we talked about family history as one thing that you can't change. You can quit smoking, you can quit drinking maybe, and you can go to the gym. You can pick your friends, but you can't pick your family. Oh, it was her? Yeah, you threw your voice over here. The ventriloquist.
She's a Yankee.
It's the quiet ones in the corner. So it's just like we talked about. Everything about cancer is surveillance. Watch you closer. We talked about what your risk is. If you're high risk, you probably need your breast removed. or your ovary or your ovaries removed by 40. We know that if people have their ovaries removed by 40, it cuts the risk of breast cancer in half. Doesn't matter if you have the gene, you don't have the gene, you have a family history, you don't have a family history. Bottom line, if your ovaries are sitting in a jar by age 40, it cuts your risk of breast cancer in half. Medication we didn't talk about, and we're going to, and surgery we did talk about. So going a little more in detail about surveillance. There are a lot of ways to keep an eye on your breast, and it depends on what your risk is as to what's done. Bottom line is, everybody should do a self-breast exam. All women should do a self-breast exam every month. Men, you know, unless you have the gene, you really, you know, and I don't do self-breast exams, and my doctor doesn't do self-breast exams. Now, if I had a family history of a strong history of breast cancer, I would consider. The bottom line is, most women, the average risk to breast cancer is 8%. Most men, it's less than 1. If a woman has the gene, it raises it to 87. If a man has the gene, it raises it to 8. So a man goes from less than 1 to the average risk for a woman, less than 1 to 8. A woman goes from 8 to 87. So it's pretty questionable if there's anything that needs to be done if a man has a gene for breast cancer. But bottom line, and there are a lot of organizations that have come out recently that said when you reach a certain age, women don't need to do breast exams. And when you reach a certain age, women don't need mammograms. And when you reach a certain age, it's all based on money. And who's going to pay for the mammogram? I mean, really, it is. And what do you care if, you know, if your chance is really small? Small for you is really high. My wife's had breast cancer. She's doing well. Her mom had breast cancer twice. She's doing well. Her mom had breast cancer, and she died when she was in her 90s. But they've all done well. They've all done well.
You have daughters?
I have a daughter, and the first thing that first thing my daughter said when my wife had breast cancer is, "What about me?" You know, Mama, Grandma, great. And now, you know, then when it happened, I couldn't say a whole lot, but now my daughter has a cancer prevention program. My wife's been checked for breast cancer, gene, mutation. She doesn't have it. That's wonderful. So my children do not have a 50% chance of inheriting a gene.
Can you skip a generation?
No, no. It's called autosomal dominant, if you're familiar with that. If you have one copy of the gene, there's a 50% chance you can pass it to a family member.
Many traits in families can skip a generation.
Yeah, in other things, but not in this.
If your aunt had the breast cancer, could, like, I'm the niece, could I have the gene for it, or?
Yes, we take family history all the way back from siblings to parents, to grandparents, to great-grandparents, aunts, uncles, and first cousins, both sides of the family. My daughter does not have the risk of having the gene. My wife doesn't have the gene. I don't have any significant family history. So my chance of my daughter having the gene is really remote. Does my daughter have risk? Yeah, my daughter has a very significant risk. My daughter has a cancer prevention program that I designed, that I emailed to her and told her the doctor that she needs to see in Atlanta to make sure she's under surveillance. So my daughter, and you know, it's a hard thing to talk to your daughter about something like this, that she just got married and just bought a house, and you know, you hadn't wanted to talk with her for years about it, but then you get to the point, you know, she's almost 30, we need to be doing something. So she has a cancer prevention program, which hopefully she's checking her breast every month. Hopefully she's seeing a doctor twice a year. Hopefully she's getting a mammogram at age 30, and consider to have MRIs prior to that. So ideally she ought to be going every 6 months, having an exam, having some kind of diagnostic procedures. Bottom line, people at risk, we start at age 20, checking their breast twice a year. We start at age 25, getting a breast MRI on them. we start at age 30 getting a breast MRI and a mammogram, and we start at age 35 putting them on medicine to reduce the risk.
What kind of medicine?
Next, good question. I'm going to bring it up. The main medicine's tamoxifen, and I'm going to bring that up. So the bottom line is, you know, my daughter's not low risk, my daughter's not high risk, my daughter's moderate risk. And that's who most people are. They're people that have a family history, that they probably don't have the gene, or they have had a test that was negative for the gene, but they're still at risk, and that's the majority of the population that have a family history. You had a question?
I got a question. What was the best candidate for a 3D mammogram? I thought those were for women that had dense breasts, or is it for?
I'm going to go over that too. So self-breast exams, everybody. And it depends on the organization that makes the recommendation, but the bottom line is you need to check your breast every month. Clinical breast exam, you need to have a doctor check your breast every year, and if you're at significant increased risk, twice a year. Mammogram, age 40, everybody needs one every year. Recommendations are varying, whether you need them, they don't help, they do help, whatever. You need them every year, so you gotta do, you gotta have. Breast ultrasound, dense breast. There was legislation that was passed this year in South Carolina that actually over half the states in the United States have passed now about dense breast surveillance. We have just figured out that dense breast increase the risk of breast cancer, and a breast ultrasound along with a mammogram helps. Bottom line is, you get a mammogram, the film's black. You have dense breast, that's white. You have a breast mass, that's white. White on white is white. You can't see a snowball in a pile of snow. So, because the mammogram can't see the snowball in the pile of snow, the ultrasound can see the snowball. So people that have dense breast, and 50% of all women in the United States have dense breast. And based on that, if you have dense breast, legislation has now required that if you have dense breast, everybody hadn't done it yet, but legislation has required that if you have dense breast, the doctor that ordered your mammogram is supposed to tell you when he sends your letter, your mammogram was normal, you have dense breast. Dense breasts increase the risk of breast cancer. And then they'll say, you do not qualify for any additional testing, or you don't. You do or you don't. And the bottom line is, the way do we decide if women need an ultrasound? And it's quite variable, and this is a new science that just started a year ago. I use something called the Breast Cancer Surveillance Consortium app. There's an app for everything. So bottom line, I have an app on my phone, and this was tested over 1.6 million women, and was validated by one of the major medical centers in the United States. And the bottom line is, if a lady has dense breasts, I just sit down with my app, I put in her family history, I put in if she had biopsies, I put in if she's on estrogen, I put in her age, I put in how dense her breast, and it pops up a number. And based on that number, I decide if she needs an ultrasound. So 50% of people in the United States have dense breasts. A percentage of those need an ultrasound to determine if they are having a breast cancer miss. I just had a lady a month ago. One of my partners retired. She had a mammogram scheduled, and I got a report because he's retired. Dense breast. You have dense breast. I had my nurse to call her, ask her, what's your family history? Have you ever had a biopsy? Yada, yada, yada. Never could get her, never could get her. And I thought, okay, to heck with it. I'm just going to take what information I have and throw it into this app and see what her risk is. I'm going to assume she hadn't had A, B, C, D, and E. I'm going to assume she just has dense breast. Her risk was high enough that she needed an ultrasound. So I tried to call her, she didn't answer. I tried to call her. Sent her a certified letter, your breasts are dense, it increases risk of breast cancer, you need an ultrasound. She answered. The ultrasound was abnormal. She had a biopsy. And there are basically 2 or 3 precancerous breast biopsy reports that significantly increased the risk of breast cancer. Hers came back, atypical ductal hyperplasia, high risk for breast cancer. So she was offered medicine to reduce her risk of breast cancer by the surgeon that did her biopsy. I just kept it in my reminder on my computer. Find out, did she get the ultrasound? Find out, did she get the biopsy? Find out, did the biopsy show anything? And find out what the doctor said. And then the last thing I saw, patient seeing biopsy atypical ductal hyperplasia, recommend tamoxifen to cut her risk of breast cancer in half. So you can cut your risk of breast cancer in half with medications. We have 4 medications. Tamoxifen is the most commonly used one. She declined medicine. I kept gnawing that bone. I sent her a letter last week. I see that you had the mammogram and the ultrasound and the biopsy and a precancerous breast lesion, and you declined tamoxifen. Please make an appointment with me so I can discuss this further with you and try to talk you into taking it. You know, everybody's afraid of the medicine too. I guess I'm not as afraid. My wife's had breast cancer. It was estrogen positive. She took tamoxifen. She didn't get a stroke. She didn't get cataract. She didn't get uterine cancer. My wife came off tamoxifen. After the usual 5 years, she went on something called a aromatase inhibitor. She hadn't had a stroke. She didn't get cataract. She didn't break her hip. You know, so all these medicines that are recommended, my wife's been on them. My wife's actually a doctor too. Excuse me?
A guinea pig.
No, she's not a guinea pig. These medications have been used for tamoxifen for quite a length of time. But, you know, and my wife doesn't make her decisions based on what I say because she doesn't really listen to me a lot. Because when my wife had breast cancer, I said, mastectomy, do it, it's gone, no deal. She said, I'm not getting my breast cut off. I said, you should. She said, I'm not. So she had she had a lumpectomy, axillary node section, radiation, chemotherapy, tamoxifen, now aromatase inhibitor. But the bottom line, these are not guinea pig medicine. Tamoxifin's been out a long time. There was a STAR study that came out years and years ago where women were placed on sugar pill or tamoxifen to see if it reduced the risk of breast cancer, and it cut it 50%. Avista is another medication that we have that women take for brittle bones, cuts your risk of breast cancer in half. Anyway, everybody do a breast exam. I got to finish in 4 minutes, right?
A portion of density in one of your breasts.
Well,
It's one section.
okay, there are 4 categories. The radiologist has a responsibility to put on the report which one, and if you're in the top you're not 1 or 2, you're 3 or 4, you automatically, quote unquote, have dense breast. They have to decide based on their criteria. I don't read mammograms, so I don't know what percentage of the breast they say it is, but they have criteria. And unfortunately, it's a very subjective thing. They've done studies of dense breast, and they've had, a bunch of radiologists here read them and a bunch of radiologists here, and nobody agrees. But you got to do what you can do. Everybody, dense breast on occasion. You got the gene. You need an MRI. Or if you don't have a gene, but yet I do a calculation and your lifetime risk to breast cancer is 20%, you need an MRI. So these are for the high-risk patients. Tomosynthesis, nobody knows absolutely sure where tomosynthesis works in this. Bottom line, it's a quote-unquote 3D mammogram. It's not really 3D, they just take shots from every direction and the computer formulates a 3D image. And nobody knows for sure where it fits into this. But I know that within the next year, certain mammogram centers in the upstate are going to start doing tomography. And if I'm correct, they're going to automatically, if a patient comes in with a certain finding on their mammogram, they're going to go ahead and do a 3D mammogram. And if I'm not mistaken, Medicare now covers for tomosynthesis. But it's a new science. So everybody, dense breasts, I got the gene or 20%, or something's bothering me, we need another diagnostic study. Medications, tamoxifen and Avista, have been around forever, most commonly used. Both of these cut the risk 50%. 2 other medicines cut the risk 50%. This one's the one that's been most used. This is the next one. The other 2 haven't been used quite as much. My wife's been on the tamoxifen. My wife's on one of the other 2, aromatase inhibitor.
Did you say Evista?
Evista.
Well, I'm on Evista,
Yeah.
but it's for my bones.
Exactly. Evista has been used probably for 20 years for thin bones to prevent a fracture. We now know that it cuts the risk of breast cancer in half. A good thing.
You get 2 for 1.
2 for 1. Okay, people like Angelina Jolie, very high risk, 87% risk. She had her breast removed, it cut her risk 99. Why didn't it cut 100%? You can't get every single cell. Removal of the tubes and ovaries cuts the risk, actually removal of the ovaries cuts the risk of breast cancer in half if you have it done by 40. But if you're going to get your ovaries out, those tubes need to be in a jar sitting on the shelf.
Must have a lot of jars on those shelves.
They do. I've been filling a lot of jars in the last 4 years. In fact, I drive the pathologist crazy. You know, there have been protocols that have been developed that haven't been uniformly used, that everybody's not aware of. I'm very fortunate in that I work with a group called the Laparoscopic Institute of Gynecology and Oncology out of San Francisco. I'm on faculty with them. And we give conferences, and it's updating cancer prevention protocols and laparoscopic surgery. So I know the people that do the studies. I have access to the studies from the beginning. And the way I drive pathologists crazy is, it used to be when we took a tube out, and this is just kinda, I'm 5 minutes over, 1 more minute. So you take a tube out, they can't make 1,000 slices, otherwise they'd be here all day looking at the tube. So let's say they took 10. But now it's known that when you take a tube out, you don't take 10 slices. Let's say you take 100. Because the more slices you take, the higher the chance you're going to pick up something. So when I first started doing this about 4 years ago, I wasn't sure that they were doing that. And I called them, and finally they said, Dr. Squires, I can tell you, all of your tubes are sliced over and over and over and over again. We never not slice your tubes a lot. I said, and you slice everybody else's a lot too. Yes, we do, gritted teeth. I said, thank you. But you know, change takes time, and usually change makes for more work. Excuse me?
The dense breast.
A dense breast, what is it?
A dense breast, what is a dense breast? We used to say, I'm checking your breast, boy, your breasts are dense. A doctor can't really say that. It can only be found by a mammogram. Okay. And why, and then to add to that, why are dense breasts high risk for cancer? It's harder to find, and your body breaks down to estrogen in your body. And you say, well, you know, I don't make estrogen. You do make estrogen. You still have some estrogen. The fatty tissue in your body makes estrogen. And that estrogen is in the breast. And the breasts don't metabolize, if you have dense breasts, the breasts don't metabolize estrogen as much. In other words, it hangs around longer there. If it hangs around in your breast longer, it's higher, it's going to stimulate something called breast cancer. And one thing I didn't add is the older you are, the less dense your breasts are, meaning, you know, when you're 20, they're dense, and then they tend to get fatty, and that is a category. Number 1 is fatty.
Do you do an uplift?
No. No, I don't. Yeah, you got to see a plastic surgeon for that. But bottom line is, so the older you are, the less dense, the more dense your breasts are when you're young and your breasts sit up. As you get older, it's replaced with fat. It's a part of life.
That's right.
Yes?
I have a question. The guy probably who designed the machine that takes your breast this way and that way probably was a man.
Yeah.
Is anybody thinking about doing something different? Because
Well, that's,
it hurts.
yeah, I know. Yeah, and yeah, they're trying to figure out something different. You know, The breast MRI has no radiation exposure. The breast MRI is more sensitive. But right now, insurance companies are not likely to do a routine breast MRI, which exposes you to less radiation, that you don't squeeze your breast, exposes you to IV.
Because I had the sonograph done, and that was
Yeah, and they've talked about thermography, which is some way to detect the heat in the breast, because the warmer areas are probably have an increased risk of breast cancer, but they've never refined that. So bottom line is no, the mammogram.
lady designing the thing.
Yeah, and they need to replace, you know, I guess the men's front exam instead of a squeeze, and then the men would probably say, let's start doing ultrasounds.
If they would do that lower on a man,
Yeah.
we'll get something done.
You're exactly right. It's like when I saw my yes.
I agree 100% everything you said.
Thank you. But it is surveillance.
We had a cartoon hanging up in outpatient surgery, showed the male version of the mammogram. It was cute.
I went to see my family doc, my internist. Every time I go to see him, Randall, y'all know Dr. Chang?
Oh, yes.
You know, he's real quiet. Can't ever tell where he is. Anyway, Randall, did I do a rectal exam on you last time? I said, yep. You lie, bend over. And then while he's in there, he says, I found 3 prostate cancers a month ago. I'm like, yeah, don't let this be the 4th one. Get out of there. I mean, good God. Do I want his finger in my rectum? No. Do I want it in there for like 50 seconds? No.
My sister and my daughter have those fibroids in their breast.
Fibrocystic breast disease.
Is that considered like a dense breast?
That is considered part, yes. The more fibrocystic breast changes you have, the denser your breasts are.
If you're like 80 or something, in your 80s, can you still get breast cancer?
Yes. Yes. The older you are, the higher your risk is breast. And you know, some people say, you know, and it's all money, you stop doing mammograms when you get a certain age. And really, I have ladies in their 90s that start doing, you know, and it's a fine line, you know. If you find the breast cancer on a lady and she's got so many medical problems, she wouldn't tolerate medicine, she wouldn't tolerate radiation, she wouldn't tolerate a surgery, should you do mammograms? And one thought is that, and this is impossible, you only do a mammogram on somebody that you expect them to live 10 more years. How do you know?
Yeah. That's right. How do you know?
You don't. So I do them on everybody.
And you said that they should stop taking them, you know, they, after a certain. like-
Yeah, and they talk about stopping them.
Yeah, I didn't. Same thing with estrogen. You're only supposed to take estrogen for 10 years, then you quit. I took it for 40 years.
And that's debatable too.
Well,
Yeah.
it didn't hurt.
Yeah.
I mean, I was lucky. I gotta say I was lucky.
Yes, sir. Yes, ma'am. Yes, ma'am. I don't. I don't. Some organizations say 75,
Oh, then I'm over.
but I actually don't. I just get them as long as. Yes.
I mean, after 75?
Yes.
That may change.
Now they will only let us check breast after in Medicare a breast exam, I think every 2 years. I get confused. Is that right?
That's like with a pap test.
Every 2 years. Yeah, and the pap
Every
and all
other
that
year,
stuff.
but look what can happen in all that time.
Yeah. And that's one thing about dense breast.
2 whole years.
People with dense breast tend to have a higher chance of interval cancer. In other words, they have a higher chance of getting breast cancer between this mammogram and the next one. And that's why we threw in the ultrasound. Thank y'all.